Our next speaker is Dr. Rishikesh Tadwalkar, who will be talking about a sudden drooping eyelid, the hits and misses. So Rishi is one of the, I think, few people in Bombay who really started doing oculoplasty and orbit, and he's trained at Arvind Eye Hospital, and he's doesn't like me saying he's very senior, but he is, and he's an excellent surgeon and teacher. And I think all of us, including me, it's very rare to find a colleague who will encourage you and help you out in your early days of your practice. And so, besides being an excellent oculoplastic surgeon, he's also, been sort of instrumental in a lot of us, sort of settling down in Mumbai into a private practice. And we've had the pleasure of doing 2 major meetings in Mumbai, our oculoplasty meetings, and we had a lot of fun doing it. So thank you, Rishi.
Thank you. Sauri, I know that when somebody doesn't have many academic achievements, you have to focus on other aspects. And sorry, I'll just move on. Since we don't have to ask anyone whether they can hear or see the presentation, let's go directly to the presentation now. So many times when a child comes to you, like this 6 to 8 year old child, he came and he was referred, and as might be a practice with many oculoplasty surgeons, referred for ptosis surgery in a congenital ptosis. But as you can see, something is not right, because especially when the parents say that the ptosis is only since 2 months, you have to listen to parents very carefully. And when you ask them to give a recent photograph from past, they gave this photograph. Now you are really alert as to what you are dealing with. Even the lid doesn't look right. The lid looks smooth and swollen, and in such cases now we are looking at some other etiology than congenital. Sorry. And what could it be? Infective, inflammatory, vascular, infiltrative. And when we think about this, what would be our investigation? There is no diurnal variation, and so we are not looking at, say, childhood myasthenia or something like this. So when we are going for neuroimaging, what we find is a typical cysticercus cyst in the superior rectus and LPS complex, and with just conventional medical treatment, the child recovers completely. So this is one of the cases where you have to remember that in childhood also ptosis can be acquired, and when we pay close attention to history, taking an examination, you would not be missing this and avoiding something like taking patient on the table and discovering that you are dealing with something else other than the congenital ptosis. So the type of acquired ptosis that we generally see are these involutional, traumatic, neurogenic with third nerve palsy, or myasthenic, other myogenic ptosis, and of course mechanical. Another case I would like to say is this 32-year-old male who complained that ptosis was gradually improving, increasing for 2 to 3 years, no history of trauma or diurnal variation. He had recurrent redness off and on and pain. So in such cases, when you look closely, the lid is it's like moderate to severe ptosis, and there is no swelling. What type of ptosis does this look like? So when we are thinking of going through the whole list, and then what additional evaluation that you're going to do, including clinically. So when we, in such cases, a comprehensive clinical evaluation itself will sometimes reveal something very simple. Like in this case, when you just lift up the eyelid, you look at, there is a big staphyloma, which was missed because the patient was directly referred as ptosis, and the treatment totally changes in such scenario. So therefore, a comprehensive clinical examination is important, and that is just how, underlined by this importance of by this case. Another patient, 27-year-old female, whose right eye appears smaller only since 2 months. Again, no diurnal variation, very mild ptosis, good light eyelid excursion. Now again, what else are we looking for in mild ptosis with a short duration? Ocular movements, as we say, no diurnal variation, full range of movements. Pupils, and why would we look at pupils is because sometimes you are having a case where there is difference in size of the pupil, which points towards Horner syndrome. And these are the cases which generally would present with mild ptosis, and therefore, and then what would be the preferred treatment of choice? Most of the times these cases, they would get better with something like a fascinella servate procedure. So therefore, again, clinical examination is important. This patient is clear-cut 65-year-old male with drooping since 6 months. He had history of diurnal variation, and on examination, variable ptosis, again a very common acquired ptosis that we see in clinical practice. He had full ocular movements and pupils were normal. Now, normally we have many tests like fatigability, eyes test, rest test, in which we can do right in our clinical setting in our office. And what has been seen is that eyes test shows a lot of high degree of specificity, like to diagnose myasthenia, which of course can be corroborated with other tests like EMG or doing hydrophonium or neostigmine test and other lab work. So in this patient, this is the pre and the post neostigmine, which clearly shows significant amount of recovery of ptosis, and so that the patient can be treated with conservatively with pyridostigmine. Now coming to the next patient, 33-year-old male, he has drooping in the right eye since 2 months. Again, he is not very sure about the variability, severe ptosis with diplopia. If we look at the movements, so the patient has ptosis in the right eye and he has adduction deficit, then his elevation is again, and he also has some amount of deficit in depression. So now when we look at this picture, severe ptosis with poor upper lid excursion, not much variability but diplopia, restricted elevation and depression, and severely restricted adduction, no visual disturbance. So here we are like facing either a third nerve palsy or myasthenia or ocular myopathy. Again, you have to remember that myasthenia can present in very, very different scenarios and different ways, and therefore it's like a masquerade, and therefore we have to look at myasthenia before look at anything else. Again, in this patient, you can see that post neostigmine, there is complete recovery of both ocular movements as well as his lid level. You can see here complete eye movements are recovered, and again this was which looked like a third nerve palsy. This patient had myasthenia. This is a isolated pupil sparing third nerve palsy where there is ptosis and restriction of adduction and elevation. Again, another patient with who has recovering third nerve palsy, where you can see that there is mild ptosis in primary gaze, but vertical gaze limitation and eyelid gets retracted when or you can say hang up with depression and adduction, and this is misdirected regeneration in a third nerve palsy. So again, a patient who presents with ptosis, but actually he has a neurological basis to the etiology. Lastly, the 59-year-old female with gradually drooping left upper eyelid, no diurnal variation or diplopia, recessed upper lid, and this is basically the classical picture of an aponeurotic ptosis that we see. And there are various approaches that have been described. Of course, the surgeon's preference as well as ease with dealing with these scenarios, they can deal with either an anterior or a posterior approach. So these generally the cases where there is quite a high level of predictability in results, because you see that either levator is disinserted or there is dehiscence, and then a simple procedure can rectify that. 23-year-old male, again ptosis following injury with fish hook, and there is no external injury mark, severe ptosis, poor lid excursion and restricted elevation. Now in this patient, there is always the conundrum, you can say that, because with no levator function, what are you going to do? Either a frontalis sling or a levator exploration with reattachment. Some authors have also described Whitnall's sling, which is a modification of a frontalis sling, only that the eyelid is attached to the Whitnall's ligament. Now here, levator exploration and sometimes reattachment, especially if the patient presents early, can give you good results. So in summary, it is particularly important that pseudotosis is clearly recognized and that a neurological or a myogenic cause of ptosis which requires further evaluation is excluded. It is important to palpate around the eyelid, evert the eyelid, look at the phonesis. You have to differentiate between a preganglionic from a postganglionic Horner's syndrome. Myasthenia, as we have seen in couple of cases, can mimic any kind of physical presentation. So therefore, a high index of suspicion is required, and we have to exclude the possibility of aberrant regeneration in cases with history of facial palsy. We have to take particular care whenever you're making a skin crease incision in aponeurotic ptosis, because the lid is very thinned out and a lid guard is used. Thank you for your attention.
Thank you, Rishi. That covered the entire gamut of all the acquired ptosis and was bang on time. And hopefully we'll be able to